All right, well, why don't we go ahead and get started, and we'll get this thing going, and then that way we can get moving, and we'll try to get these other missing physicians caught up, and they can always watch the recording, of course, which we're doing. So tonight we are giving an overview of the episode quality improvement program with an eye towards the eye physicians, and there are essentially. The Episode Quality Improvement Program is a value-based program specific to Maryland that has been developed in concert with the total cost of care. And tonight we have two folks who are going to talk about it who have forgotten more than I've ever known about it. I'm Gene Ransom, CEO of MedChi, and Jessica, who works with CRSP, will be doing the bulk of the presentation. And Will Daniel, who is one of the higher-ups at the Hscrc, is going to do a couple answers around the Prometheus episodes and answer questions around policy. I really appreciate you guys taking time from your schedule to be on here. These programs are successful because there are a couple principles that, as we've been developing them in concert with the state, that we followed. First of all, they're physician-driven, and we're trying to get as much input from clinicians as possible so they make sense and are good for physicians and patients. Secondly, they're voluntary, and I think that's really important. There's nothing here that's mandated. You can either take it or leave it. And in fact, the reason we're doing this call is to find out whether or not we should include certain Prometheus codes and ask CMMI to create programs around it. So it's up to you. And the other great thing about this program, in my personal opinion, and Will might disagree, but this one has no downside risk. And I like that. So that's one that there might be debate around, but that's neither here nor there for tonight. So hopefully we can all learn a little bit about the Eye Society, and I'll go ahead and about the Eye opportunity under the Episode Quality Improvement Program. And I want to thank the Maryland Eye Society for doing this jointly with MedChi tonight, and Ginger, the executive director, for the work she did in helping set this up and putting it together. And I will turn it over to Jessica to give you an overview of the Episode Quality Improvement Program and the potential opportunity for ophthalmology.
Thanks, Gene. So we are going to step through the EQIP program today. Since there might be a mix of people who have heard of the program before, we're going to really deep dive into like some of the policy that is across all specialties. And then, as Gene mentioned, talk about the episodes that could be available for your specialty specifically. So let's jump right in. So as we mentioned, Maryland is under the total cost of care model with the priority of reducing costs and improving quality in both hospital and non-hospital settings. Due to the model, historically, Maryland physicians have been largely ineligible to participate in national Medicare value-based payments. Therefore, the state decided a couple years ago to go out and create their own program with specialists as the focus. So EQIP is the very first of this program, and it's designed to achieve that cost and quality improvement that we talked about both in and outside of the hospital setting. So the four key features that we'll emphasize during today's presentation have to do with that is physician focus, as Gene just mentioned. So we really want this to be centered around physicians owning and monitoring their own performance in this program. The second is that EQIP is designed to have a upside risk only. There is a savings accountability, which we'll get into more detail later, but again, there is no downside to participate, just upside only. And then additionally, since it's the first program of its kind, it was designed to be attractive to join and allow physicians to get familiarized with this type of program, and also designed to be aligned with the Care First episode payment program. EQIP has a similar design and approach, although the administrative burden across the Care First and the Medicare program is slightly different, which we'll also discuss. And finally, EQIP gives participants the opportunity to take part of an AAPM model, and therefore they can be eligible for that 5% bonus if both quality and savings goals are met. So the underlying methodology, which we'll hear about a lot here, that we're using to define episodes in EQIP is through the Prometheus Episode Grouper. Again, for the first year, we did select 3 specialties, GI and general surgery, ortho neuro, and cardiology. We have just shy of about 2,000 different physicians that have elected to participate in year 1 under those specialties. And we're here to talk about opportunities for performance year 2. To take a step back, when we say EQIP is a value-based payment model, there are really 3 main outcomes that define better value, and we hope that EQIP can achieve. So the first is that you increase quality while cost remains the same. The second is that you keep quality the same, but you decrease cost. Or in the ideal state, again, which we hope EQIP can achieve, is we increase both quality and decrease cost. That would be a wonderful achievement and goal of this program. So when it comes to value-based payments, the EQIP program is a bundled payment program. So across the nation, bundled payments have been proven effective to help control costs and improve quality. CMS has actually shown about a 4 to 6% reduction in their bundled payments programs, which is why we designed EQIP to mirror similar programs. There are 3 primary elements in the EQIP program. One is that the physician agrees, to be part of an episodic-based payment. Once a baseline period is identified, the cost for that episode is calculated to identify an appropriate target price for the performance year. That target price is then used to assess the performance, and then finally, the performance year costs are compared to that set target price to identify if savings were achieved and if the participants are eligible for incentives. The idea is to have this as sort of a straightforward program as possible. Therefore, the physicians can monitor the performance and track the success of their participation in the program. So I mentioned a couple of slides back about Care First. So let's talk a little bit more about this. So EQIP is designed as a multi-payer demonstration. And what we mean by that is that both Hscrc and Care First worked closely over many months to align that episode program definitions. The Care First program is called their Episode of Care program, and EQIP is the Medicare program. They have parallel incentives and similar design elements, really with the goal to make this easier for our physicians and reduce the administrative burden for practices to have to understand different algorithms or methodology. And again, the fundamental level of the Prometheus Episode Grouper is the basis for both of these programs. So while Prometheus is using both, EQIP does have a separate incentive and policy that was applied to the grouper, but the core principles and design are very similar. So let's get into EQIP. So with many policies, we hear lots of acronyms. So to start, I will just review some of these like definitions and groups up front. You will first hear us reference a CRP entity. And this is essentially one Maryland hospital that was selected, in which the care partners will sign a standard contract or agreement with any physician that wishes to participate. And we'll go a little bit more in detail about this, but essentially the CRP entity is what the state is using for a sole administrative function to be able to pay out those incentive payments to the participants in the program. Moving to that next column, we have an EQIP entity, and this is the main participation function of the program. So an EQIP entity can be either an individual physician or individual care partner, or it can be multiple or a group of physicians. So essentially, it could be a single practitioner, it could be an entire practice, 2 practices joined together, a subset of a practice. Really, it is any grouping that the physician agrees to participate in, and they are electing to be evaluated at that level. So what I mean by that is that performance evaluation is always at the entity level. So it could be across specialties, it could be just within one specialty, but again, that performance is always at the entity. And that entity will receive one lump sum incentive payment based off of that aggregate performance. The next we get to care partners, which I reference a little bit, and that's really what we're calling our specialty physicians. So these are our actual providers who are practicing medicine and performing those care interventions. Each care partner will be required to sign that standardized agreement with the CRP entity. the care partners will continue to receive like normal fee for service payments for Medicare. And again, there is that potential for the 5% bump, but essentially it's sort of business as normal. This exists as a complement to the different billing offerings that you have. So finally, we have CRP and Hscrc, and really these are the policy drivers. We are the ones who calculate and monitor performance. We determine incentive payments. We maintain most of the, if not all of the reporting requirements to CMS, and really trying to make the reporting as minimal as possible on the EQIP entities. Now, this last role in the bottom box here is called an administrative proxy. And this is really a support role that any EQIP entity can delegate the management of their program to an individual that they see fit. So this could be a practice manager, a truly external consultant, really is whomever the entities would like to engage to help them manage their participation and performance in the program. So the CRP entity, so we mentioned that this is one Maryland hospital that's taking on that CRP entity role. And for performance year one, that was the University of Maryland Medical Center. And by having this partnership, it enabled EQIP to be recognized as that AAPM status with CMS. So while UMC was selected, any qualifying physician in Maryland is eligible to participate regardless of prior or current relationship or even their current privilege status at UMC. So essentially a physician could never have even touched the hospital system and they're still allowed to participate in the program. And that's because the CRP entity or UMC really has the two main roles of receiving a list of care partners and generating that standard contract for them to sign. And secondly, they are cutting the checks for that incentive payments. They will not be actually calculating the payments. The Hscrc will be the ones calculating that and essentially telling who to pay and the specified amount if incentive payments are earned. So because of this administrative role, UMC will not have access to any protected health information. There's no data sharing agreements that happen between individual physicians, the practices, or UMC. And they also will not have any access to the performance analytics and really are truly quarantined to an administrative function that we just discussed. You know, it can be a little bit daunting signing a contract with so we're trying to make sure that we feel that hopefully you all feel comfortable with understanding their role in that very refined, defined administrative lane. So now let's dive into the requirements for participation. And really there are three main buckets. The first, with really any of our programs, a care partner must qualify with Medicare, which means that they need to be up to date in the PICO system. And as a note, if you are interested in participating in the second year, PICOS is one of the things we do recommend people to check in prior to the start of the year, because it's quite simple, but also if things are not aligned, it does unfortunately kick you out of the program, and we want to make sure that people are squared away as much as possible going into the year. The second is that we do require care partners to use CERT or an EHR and CRSP for the health information exchange, and all of those combine to pass the CMS vetting. And then there's the enrollment requirements. So this is where it starts at the definition of their entity. So an individual physician must determine how they are deciding to join, how they are enrolling, again, by themselves or with multiple care partners. From there, that entity, that group that they decide to participate in, will agree to quality metrics. They will sign a care partner agreement with the CRP entity. And finally, they would designate a location in which payment will be sent. And as a reminder, that payment is the same across the entire EQIP entity, whether it's a single person or, again, multiple physicians. And the final piece of participation is the episode thresholds. So here, the episodes are determined just off of Maryland Medicare beneficiaries. So for a single episode, and we'll get into a list of what those episodes are in a bit, for a single episode, there is a minimum requirement of 11 episodes in the baseline period. The baseline period is calendar year 19. So again, the minimum number is 11 for the entity. And then also across all episodes that an entity elects, we must see at least 50 total episodes in the baseline. So for example, if an entity selects 4 different episodes, each of those must have a count above 11, and adding the quantity of all 4, it must be at least 50. If a entity chooses to selects only 1 episode, they have to have a minimum of 50 episodes for that one single episode, since they must meet both 11 and 50 minimum requirements. The second part of enrollment has to do with selecting the intervention. So what that means is that an EQIP entity must select what interventions and performance improvement opportunities they will implement in order to achieve the program goals. EQIP entities can implement a range of activities and processes. They typically fall under these 3 major clinical, or these major categories. The first one is clinical care and care redesign, which means implementing new evidence-based protocols in their practice. For example, a discharge planning tool could be used to facilitate selection of the most appropriate post-acute setting of care. It could also mean a standardized process for provider follow-up are set. The standard could include sharing a discharge summary with the PCP, or scheduling a PCP visit within X number of days after discharge.
Jessica, I see Dr. Glasser has his hand up.
Oh, sorry, go for it.
Yeah, that's been going a mile a minute. Do you want us to hold questions until the end?
No,
Okay, so,
please interrupt, but I can't necessarily see the chat. So someone just holler at me to stop.
yeah, so I didn't follow your comment early on about why MDs are locked out of other APM opportunities. I know physicians at Hopkins, are in the APM. Is this primarily for physicians in smaller groups?
No, and Will, you can jump in if I repeat this incorrectly. But historically in the past, some of the larger Medicare programs have specifically excluded Maryland providers because we have this unique total cost of care model. I don't know if there's specific reasoning behind that.
So I think this is specifically a comment around BPCIA, which did not
I don't know what that is.
on hospitals to participate.
Yeah.
That's a bundle payment program, Dr. Glasser, that we don't have in Maryland. It's a national program.
Okay.
And there were a couple national AAPM
Gotcha.
programs that were excluded in Maryland. The oncology model was excluded.
Right.
Yeah,
Well, none of those are relevant to ophthalmology, though, because there aren't any bundle payments for ophthalmology. You made a comment that qualified participants in the AAPM would get a 5% bump. I don't believe that's correct anymore unless new legislation extends it. So the 5% bump is over. It'll be a 0.5% bump. Is that correct?
It is correct in the future. I think it ends in 2023, if I'm not mistaken.
It ends at the end of this year, I believe.
Ends in the end of this year.
Yeah, it does. So the folks who are in EQIP for this year will receive the 5-point bump, and that payment will be based on their Medicare receivables for 23, and they'll get the payment at the end in 24 as a bonus payment. But
So
they
it's a
had to
two-year
be in
look
this
back.
time.
Right.
However, just not to get too far into advocacy, because we really want to focus on the program. There is something called the Value-Based Act in Washington that MedCat and the AMA are pushing forward to extend it, and there are other discussions about extending it. So, you did correctly say, Dr. Glasser, that if we return to MIPS, there is a 0.5 bonus on top of your MIPS score on top of that if you're in an advanced payment model. So this is like the other federal advanced payment, subject to any of the changes that the Congress makes legislatively. So that is an important point to understand. I think by the time open enrollment occurs with this in August or September, in that time period, and certainly before you sign a participation agreement at the end of the year, you will have clarity with regards to what that is, so you can help make a good financial decision as to whether that makes sense and if the 5 points really is the determining factor. And obviously, it's much more attractive if we continue to have the 5-point bonus for advanced payment models. And I, speaking as the CEO of MEC, I hope that we continue to do that.
Right. Understood. I appreciate that. And the next question is sort of related to that. And you may want to tell me you don't want to get into that until later, so just say so. But what is the incentive other than the 5%? But what kind of numbers are you talking about? There's no downside. What's the maximum upside? What have people actually achieved who have been in the cataract or glaucoma programs in other Prometheus situations?
Yeah.
Or is that too much detail?
Good questions. I think we don't know, and I don't think there's any other Medicare program that's run on Prometheus. And so I think you guys could have the pleasure of being the first to work in the cataracts and glaucoma episodes. And so I don't think we can give you an estimate of how other people have performed in those episodes. This is also our first year of EQIP, so we don't yet have any sense of how other Maryland providers are doing in their episodes. So I don't have specific answers there. We do cap the risk in EQIP, and so you can't earn more than 20% of your target price. An incentive payment, 20% would be a shockingly large amount to say that's not likely. And so I think my simple answer is,
we don't know yet.
You can earn as much upside as you create in savings.
Yeah. So, and that's a fair answer, no data yet. I actually chaired the group that developed the cataract cost measure for MIPS. And there are some really critical issues, like what are the trigger codes? What are the things that actually count towards costs? Are you going to get into that later on in this talk, or is that something that is a black box to us before we sign up?
So we can follow up with the specific codes. So one of the things that's unique about Prometheus, and I think many of our physicians many of our actuaries do not, is that only relevant costs are included. So there's literally a list of procedure codes and diagnosis codes, and any cost that is one of those two things would be included in the episode. Anything that doesn't is excluded. This is different from the BPCIA, other CMMI models that are total cost of care models. So we can follow up with a list of both trigger codes for those episodes and the related cost code.
What is included? And then one last one, and that was Jessica, when you're talking about the thresholds, I think you said 11 or something for a single episode and 50 across all episodes. So it's pretty easy to get 11 cataract or glaucoma patients. It should be easy to get 50 of them, but is that 50 for each individual specialty, or is that across the whole EQIP program?
It's across the group. So it's across the entity that you're choosing to participate in. So
Right.
obviously there's an advantage of joining as a group with more physicians, because those thresholds will be much easier to hit versus if you were joining solo.
Yeah.
Okay, thanks. Thanks for filling me in.
I wanted to make one other point, Dr. Glasser, and these are great questions and actually very helpful, kind of getting us right to the quick. We're talking about the Prometheus because the way EQIP was set up, it is very easy to add the Prometheus episodes. If the Eye Society or the National Eye Society even has an idea of a value-based program that they think makes sense, we are willing to look at it. It is a much, much more complicated process and takes a long time. Whereas the Prometheus episodes, we can add, I wouldn't say easily, but quicker. So if there's something that you guys have been working on and you really think this might work, this might be a way to test it out in Maryland. So I know you've done a lot of work on this on a national level. So if there's something you think makes sense, we're happy to have a discussion about that. I'm happy to talk to you about it. We can figure out how to do it.
Yeah, we can talk offline. I don't want to take your time for that kind of discussion now.
Let me make one final comment on these thresholds. So it's 11 at the group level and it's 50 at the group level. Once you enter as an EQIP entity, we basically treat that EQIP entity as a single entity, no matter how many doctors there are. For instance, when we talk about the target price, that target price will be the average across all episodes initiated by all those providers. So there is not a single target price for each physician. There's a single target price for each entity.
Oh, not for each episode, for each entity?
No, sorry. There is a separate target price for each episode, but not each physician within that episode.
And I'll add on to that and say that in performance year 1, we've really seen a huge range. We have a couple of entities that are single physicians, and then I believe our largest entity has over 1,000 physicians that joined as one entity. So I think, after the year ends, we'll see, I guess how the grouping kind of played out, but there was a huge range in, I guess, how people selected to participate in this program. Okay. And as I mentioned, it's sort of hard for me in presentation view to see any hands or chat. So I'll count on Jean or anyone just to unmute themselves if there's questions. We have a small enough group. Let's keep this pretty informal. Where were we? So we're talking about the different interventions that are selected. In addition to the care redesign, we have that education, beneficiary and caregiver engagement, which really sort of centers around education. And finally, care coordination and care transitions. And this really could be like a care manager that's assigned to follow a patient across different settings, to coordinate follow-up appointments, connect someone to community resources, things like that. And just as a comment, EQIP is a site-neutral program. So selection of the most cost-efficient and high-quality setting of care is a performance improvement opportunity. So this could mean shifting from a more expensive hospital unit to a hospital outpatient or even an ASC, which could, as long as you can manage the patients effectively in that setting.
So Jessica, that's another big issue that we encountered when we did the cataract cost measure for MIPS, because that wasn't a bundled payment. That really did try to equalize things. And not every physician has access to an ASC. So I think if you don't have access to an ASC, you probably don't want to participate in this.
So definitely it's a fair point. When we get into a little bit about how the target price is calculated, I will say it's based off of that entity's baseline performance. So it is not one target price that's set across that every entity needs to hit. So if your initial baseline has a complement of mostly, let's say, hospital-based procedures, your target price is going to be reflective of that. Versus if you are able to perform procedures in the ASC, your target price is going to be different because, again, the complement of procedures done during baseline reflects already that lower cost setting.
But I thought the target price was set per episode, not per physician. So if you're in an HOPD, you're going to be subject to the same target price as the guy who does all his cases in an ASC. Right. And you'll be at a disadvantage. So
you could form your own entity, right? And then you would be compared to yourself in a hospital.
Okay.
You want to be careful who you partner with, but probably a good, idea for everything in life, but definitely, if you do everything in a hospital and your partner does everything in an ASC, you're going to get the weighted average of the two and it's going to be a mess. Gotcha. And you're better off doing two entities.
Makes sense.
So there were 15 episodes that were selected for performance year 1. You can see them here. Obviously, none of them were specific to your specialty, but to get a sense, most of them were procedure-based, and you'll see a number that's following each one of these, which has to do with the procedure length, which I'll explain in a few slides from here. And now we can get into proposed Prometheus episodes for performance year 2. So these are sort of on the book, on the shelf, ready for us to implement if there is interest. The 2 that were aligned to the ophthalmology specialty was cardiac surgery, as well as glaucoma. Cardiac surgery is, oh, sorry, yes, cataract surgery. They're very different. Is considered a procedure. So what that means is it is triggered based off of a CPT and relevant ICD diagnosis, and it follows relevant costs over a specific length, in this case 14 days. Glaucoma is considered a chronic episode, and we'll get into a little bit about how that attribution and methodology is done, because it is slightly different than something that is strictly procedure based. Additionally, for performance year 2, we are implementing some episodes that are in this ED bucket. These are not Prometheus episodes. This is something that our ED physicians worked very closely with MedCai, with Hscrc, to advocate for creating these episodes. And this is sort of what Jean alluded to. If there's only these 2 currently in Prometheus, but if there's an interest for future years, we can do something similar. And Will, I don't know if you kind of want to talk a little bit more in detail about how that process would work if there's interest.
Right. So thanks, Jessica. So we chose episodes from Prometheus. They have 93 episodes that we can just pick off the shelf. We did that mostly for convenience sake, so we didn't have to develop 93 episodes on our own. That being said, we're not adverse to developing additional episodes. So if you're interested in developing an episode that doesn't fit within the Prometheus episodes, please just let us know, and we're happy to work with you to create additional episodes. The ED episodes that Jessica just talked about are an example. We worked with the ED physicians since they didn't have episodes that very clearly mapped into the Prometheus definitions, and we anticipate adding them for year 2. The only constraint is basically our staff time. So developing episodes is a fairly time-consuming process. That means that if you're interested in creating your own episodes, it behooves you to start early. We would be talking about starting episodes in year 3 of Prometheus. That would be the start of 2024. And that lead time is necessary for us to do all the development work on the back end. I think actually this is mostly for the other specialty groups, because I think glaucoma and cataract surgery are pretty clearly up your alley. With some of the other episodes, we've gotten comments back. UTI, for instance, doesn't necessarily always go to a urologist. It's frequently treated by internal medicine. We did our best to pick out what episodes align with your specialty. We're not clinicians, and so we don't always know who treats them. And then secondly, some specialties don't yet have episodes in the Prometheus, so we would develop them with those specialty groups. Bless you. If you were going to develop a new episode, we need to know the following things from you. The first is ICD-10 codes that will be used to identify when an episode begins. The second is an attribution rule to determine which physician the episode will be assigned to. So a brief comment here. This attribution rule could be pretty straightforward. The person that's performing a cataract surgery gets the cataract surgery episode. It could be more complex. Jessica talked about the chronic episodes. In a chronic episode, there's really not a single event that identifies a physician as the one that's responsible for that patient over a long period of time. And so we have to come up with alternative attribution rules, such as attributing the episode to the physician that provided the most office-based E&M services to that patient, for instance. You're not limited, so if you have something very clever in your head, please just let us know, and we'll work with you there. And then second, we need a list of ICD-10 diagnosis codes that identify which costs are relevant to the episode, or if it's easier, which costs are irrelevant to the episode. If we get those three things from you, we're happy to work on any sort of episode you're interested in, with the caveat that, we do have a limited capacity to develop episodes, and we will triage them in some, algorithm based on how many doctors we think will participate in those episodes, and then failing that, first come, first serve basis. Back over to you, I think, Jessica.
Sounds good. And I apologize if there's some background noise in my household right now. Okay, so let's go into the policy and methodology, and feel free to jump in if there's questions, and hopefully this answers maybe some of the how that we talked about beforehand. So the policy really is broken into two buckets of methodology. The first is that actual Prometheus episode definition, and this is where the development of triggers and attributed cost is determined. And then the second is the sort of policy side about how target price is set, the parameters for shared savings, quality measures, which specific episodes are going to be included, and of course, aligning the state's policy with CMS, which does include QP status if applicable. So the Prometheus, Prometheus Episode Grouper, it is an algorithm that has been in development since about 2006. It is currently owned by Change Healthcare. That is the vendor that we contract to run this. One of the primary reasons for selecting Prometheus is that it does promote that care coordination and collaboration across the continuum of care. And over its years of development, it really has had a goal of pinpointing what costs are actually relevant to an episode, and therefore can closer align with actual physician accountability to that episode. Another positive, as we mentioned a couple times here, is that there's 97 already ready to go. And while we're only using 15 for performance year one, you saw from our list, it really gives us the opportunity to rapidly double or even triple that in future performance years, if it is one of the standard episodes that have already been developed. So this flow chart is really a very high level of how the Prometheus methodology assigns services. So again, they start with everything, the total cost of care, to ensure that you're getting a full view of what's happening for a population. From there, the Prometheus looks at costs that are relevant to the episode and takes out or excludes costs that are not assigned or considered irrelevant to the episode. What are in those relevant diagnoses to the procedures and the services that are assigned to them, those are the ways that they identify those relevant costs. It's typically or almost entirely done through ICD-10 coding. And from there, those relevant costs are then split again into two different buckets, sort of typical care or expected care, and then potentially avoidable complications. Within the typical care category, you have the idea of sort of the core services that are applicable to that episode. Then you have the other relevant services that are expected to be included. And within that, it falls in sort of routine and potentially overused services or setting selections. And this is where you
Jessica.
see.
It's about burden. Who does the converting of all the CPT codes to ICD-10 codes and make sure that the crosswalks are right? Because we don't bill ICD-10 codes for procedures.
So everything here is based off of claims data. That is what is used to determine all of the information.
Right. So we don't submit ICD codes for claims. We submit ICD diagnosis codes, but we don't submit ICD codes for procedures.
Right. Yeah. So we base these off of CPT procedure codes, and sometimes when we're talking to the hospital outpatient departments, they do use the ICD-10 codes. We use this material for both, but so the triggers are either ICD-10 procedure codes, ICD-10 diagnosis codes, or CPT procedure codes.
Okay, so it can handle CPT code. No one has to convert them. Okay.
There's a mix. I apologize for misunderstanding that. So in those sort of two green buckets that are highlighted here, that is potentially where there is opportunity for cost reduction and quality improvement. A simple example could be that certain labs are being ordered to frequently compared to sort of the usual case across the state, or as we've mentioned previously, if the opportunity exists, there can be a shift into a lower cost setting of care. So one key aspect also of the Prometheus methodology is this idea of the potentially avoidable complications. And this is when you start to look at the alignment of negative outcomes or experience for the patient with the cost of that care. When performance data and baseline data is available, we do give details associated to anything that is categorized into that potentially avoidable complications category. So the Prometheus episode really revolves around a single triggering event, and this is sort of we talked about beforehand. So as mentioned, usually this is done by a procedure or CPT code, but also can be done by a diagnosis. If you guys are interested in those specific list of codes for those two ophthalmology episodes, we're happy to give you the detail of that. And then typically for a procedure Prometheus episode, there's a look back and a look forward period. And both of those timeframes are configurable based off of that episode. So that pre-trigger period is typically 30 days. And it's really set, that period of time is set to capture any pre-surgical care, labs, workup, radiology, et cetera, that would be considered routine for that procedure. And then the post-trigger period is essentially following that beneficiary for a set period of time and counting again that relevant cost associated with that surgery. For the cataract surgery, that is a 14-day length after surgery. And I would say for our procedure episodes, we have 14 days is actually the shortest days, and then the longest is like 180 days post-procedure. So again, those windows can really vary. And the Prometheus model, like again, combs through all the claims and aggregates them into episodes to determine what those relevant costs are within the time frame that was defined for that episode. So chronic episodes are different, as Will mentioned. So these are not triggered based off of a discrete event, as we discussed beforehand. And they don't, and therefore we've sort of developed an alternative way to attribute them. And two of the ones are attributing them with the plurality of those E&M codes. So as mentioned, the physician that sort of touches that patient the most over that year's time period. An alternative method is also looking at a physician with the highest cost associated with that E&M code. And I think, you know, if there is some immediate feedback associated with glaucoma and what would make the most sense for that, we're happy to hear that. Also feel free to think about that for a moment. Like I said, these chronic ones are slightly different and not as clean, shall we say, and we're happy to work with and actually would love to hear the feedback of what you think the best recommendation would be to sort of attribute that glaucoma patient to the appropriate physician.
Yeah, so you'd have to look at E&M and the I codes, the 92002 through 92014 codes, because a lot of ophthalmologists use those for the office visits. One of the problems we used to have was ophthalmologists would get attributed, the pneumonia because they saw the patient monthly for their macular degeneration and had the predominance of E&M codes, but they had nothing to do with treating the patient's pneumonia. So you have to have a mechanism in place to make sure that ophthalmologists are only being measured on the ophthalmology episodes. How long a period do you measure the chronic episodes? Is it like cost in a given year or cost in a given quarter? Or?
It's a year, I believe, Will. Is that correct?
Yeah, it's a cost in a given period, and I think all the episodes have different lengths, and I can never remember.
And then another important question about costs, particularly for glaucoma, because we've actually thought about this at the Academy. Most glaucoma patients don't need surgery. Most of them are managed with medications, and there can be a huge variability in cost depending on what medication is prescribed. And that opens a whole bunch of cans of worms, because are you asking what the cost is to the program? Are you asking what the cost is to the patient? And are we trying to do this in a way that the physician actually has some control over the costs, or is it totally random? And if you're looking at prescription drug costs, I would say to you that it is close to totally random. I have no idea when a patient comes in if his carrier or pharmacy benefit manager has decided last month to change the medication that he's been on for 2 years from something that costs the program very little to something that costs the program a lot, just because of the shenanigans that go on behind the scenes that the physician has no control over and no knowledge of. So I think that's going to be an important question. How do you manage, and how does the physician know what drug costs are? Where does that feedback come from?
Right. So it's an excellent question. And I particularly like it because Gene has been bothering me to get the Part D drug costs included for a long time. And this is a good example of why we don't include Part D drug costs. And so this is not going to include the prescription drugs. It'll only include the Part B office administered drugs.
Let me add something to that, though, that's important to understand, Dr. Glasser. So one of the benefits of EQIP is it models after the Care First value-based program. And I believe that Care First in Maryland has offered some value-based contracts. I'm not clear on the Care First program. This is obviously a Medicare program, and D is excluded here. I'm not clear on the Care First program whether they're including the drug costs or not. So I think that's a really important question for any of your colleagues who are entering into those agreements with Care First to ask. The legislation that we just worked out with Care First does require data transparency in it. So you should be able to get it. But I think that's a really important question on the other half, unrelated to this program. And I do think, go ahead.
Data transparency is one thing, but timeliness, the patient's in the office now. And I don't have time to go on a website and see,
Well, I'm talking about knowing before you enter into the contract. I'm talking about knowing what they've included and how they've included it. So my point is that the D is excluded in EQIP, but EQIP again is aligned with Care First. It's not clear whether Care First is including drugs or not. I'm not sure on that. So I just want to make sure that I don't want somebody on the call to think, oh, I got offered this value-based contract from Care First on ophthalmology, on glaucoma, and I don't have to worry about drugs because Will said Part D is not included. The Part D is not included just on the EQIP side. I don't know the answer on the Care First side.
Okay.
And we should do value-based care for drugs. Maybe not in these programs, but we need to figure something out to handle drug costs. But that's another fight for another day.
Then the question, if it's glaucoma, where is the variability in cost going to be? For most of the patients, there will be no variability if you're not including drug costs. And only the patients who go on to surgery are going to look expensive. And if you happen to have a referral practice or a glaucoma practice, you're going to be doing a lot of surgery on glaucoma patients, and you're going to look bad in this program. Whereas if you just are a comprehensive ophthalmologist, you treat all your glaucoma patients medically, and when they get bad enough to need surgery, you send them off to a glaucoma specialist. You're going to look good. So I think people really need to look at this carefully, and it might not be something that a subspecialist would want to participate in. A glaucoma subspecialist would want to participate in, unless there was some way that gets evened out or taken.
So as a reminder, everyone is compared to themselves historically. So your target price, let's say you do 80% of your cases have surgery in your baseline period. 80% of the episodes that we use to calculate your target price on will include surgery costs. And so, you only look good or worse relative to your improvement to yourself in a previous period. And so there's no specialty comparison.
How does that work with the one target cost per episode? So you're measured against two things. You're measured against the target for the episode, and you're measured against your own performance.
Well, so when I say your own performance, I mean the entity that you entered at. So there are dynamics of that you need to be very careful of. So
Gotcha.
for instance, if you have somebody who does a lot of surgeries and they leave your practice and you're left with nobody, people who don't do surgeries, then you will look good relative to what your practice looked like previously. We have a bunch of rules to try and control for what we call MPI drift. I guarantee you, if you choose to participate, all those rules will drive you crazy, and I apologize for them. But the intention there is to make it so that you're compared to yourself and not, to your peers who might be different because they have a different subspecialty, for instance.
And frankly, Dr. Glasser, this is one of the reasons that we insisted this program have no risk. And in that case, you can do it and see how it works out and get used to it. And the second point I wanted to make, and Will and I have done several of these meetings with the physicians who did the program this year. Everybody got their data and they had lots of questions about it, and they get to see it and understand it. And it did come through, and some of the orthopods said, man, I don't know if we're going to be successful or not, for example. So you're going to see your data and you can make a decision on how you move forward.
At what point is risk involved? Does that happen a few years down the road?
So good question. And Gene alluded to this previously. So I think from the state's perspective and the staff's perspective, we would very much prefer to run a two-sided risk program. We have a model where we're required to reduce costs for the entire state of Maryland. And, I think having two-sided risk would certainly help that. Strangely, we were told by CMS that it was a bunch of hassle to create a two-sided risk program. So we do not foresee the downside risk being added within, the next 3 or 4 years.
Okay.
And we have concerns about risk in the negotiation, the Care First legislation, Dr. Glasser. That was one of our sticking points. And in that legislation, under Maryland law, for those, the law puts a cap at the risk at 10%. And that was what we were comfortable with. The Maryland primary care program has 10% at risk, theoretically, because it's 10% of the money that you get paid. So it's a little different.
Okay, that's helpful.
Okay, so we talked a little bit about this chronic episode and the two different ways that we can attribute it. Just as a note, that if it is attributed as like the plurality of, let's say, the E&M codes with those I codes, as you guys just mentioned, a physician may not know if that patient is attributed to them until the episode has completed. And again, that's very different, whereas it's the straightforward, I know I, as a physician, performed a surgery, that patient is attributed to me. So chronic is slightly different associated compared to like the procedure-based episodes, especially from a participant's perspective. Okay, now let's get a little bit into that target price and incentive payments that we've alluded to. So this is, when we talked about sort of our buckets, this is now we're outside of the Prometheus bucket and we're sort of in that Hscrc CMS policy bucket, and how we determine if an incentive payment should be earned. So we set a target price based off of the episodes in a baseline year. So for the first year that entity is participating in an episode, or let me rephrase that. For the first year that an episode is part of EQIP, we are using calendar year 2019 as the baseline. So for example, if you guys choose to join next year, calendar year 19 will be your baseline. However, let's say in performance year 3, an entity chooses to elect cataract surgery to participate in, their baseline will be the prior year, since they did not join at the start of that episode being an opportunity. So this is the case for the first 3 performance year. So again, if you choose to participate next year, for the first 3 performance years, 2019 will be used as your baseline. So each EQIP entity will be assigned their own unique target price for the episodes. So to do this, as we talked about, it's the weighted average of the cost of the episode for all the care partners within an entity. And then the aggregate of this is used to create a unique target price for that EQIP entity as a whole. We then trend that baseline cost forward to make it comparable to the applicable year. So next year for 2023 costs. It also allows entities to compare their real-time target price to their real-time performance cost. However, we must note that the final target price is not finalized until the end of the year when that final inflation factor is applied. But for the most part, you have a sense of what your actual target price is. We just have a small asterisk next to it that it does get finalized a little later. So as we mentioned a little bit beforehand, it's important to note that target price is set independent of that care setting. So that means across all the different care settings that a practice may provide their procedures, we assign a singular target price. So this goes back to the grouping or how a physician decides to elect to participate. And that weighted average for target price is based off of that group's history. And the reason behind this is we really want the cost to follow the physician and be measurable across all of your business. And in addition, due to our total cost of care model, we know that the gap between a hospital procedure and an ASC procedure is far larger under our Medicare fee-for-service than in commercial payers. So we want to align incentives between that physician and hospitals to shift to a lower acuity procedural at the lowest cost setting when appropriate, knowing that that opportunity may not exist for everyone. Which is again why that historical data, target price is based off of your own historical data and your own complement of patients. So the incentive payment methodology. So that first step in the incentive payment is that target price that we just talked about. At the end of the performance year, we assess the results across all the episodes in which an EQIP entity is participating. And determine if the performance period costs are less than the target price to determine if savings have been met. We do require a check of at least 3% savings. And the reasoning behind that is to ensure that the savings are considered statistically significant. With that check, once that is met, the savings fall into one of 3 tiers for shared savings. So using your baseline data, EQIP entities are compared to statewide experience and essentially ranked on their efficiency. So this rank will give us the relative shared savings that would be paid out. Higher cost providers are ranked lower and thus have a lower percentile in sharings, whereas our higher performing our higher performing entities will be ranked higher and they have a larger shared savings. So that lowest ranked tercile, so if you're ranked below the 33rd percentile, it has a 50-50 split of the savings with the state and the EQIP entity. That middle tier has a split of 65%, and then that final tier has an 80% split. And the idea behind this is that we acknowledge that it's harder to create savings if you already at baseline are considered relatively efficient compared to the state. So that's why we have that tiered breakdown. Now that we know the shared savings, we move into the third step and take into consideration the clinical quality score. Quality is important. It's considered a base foundation in the value-based payment models. And it ensures that outcomes of the program are not entirely cost focused, but also ensure that we are looking at improving patient outcomes as well. So therefore, 5% of the shared savings is withheld and essentially earned back based off of the performance of the quality metrics during the performance year. So all those together, the last step before the shared saving is paid is that we look at that cap. And we mentioned this a little bit earlier. Due to CMS, there is a cap to ensure that payment is no more than 25% of the prior year's Part B payments. Again, that would be a very, very large target, but it is capped at that amount. Once all of those steps are completed, the Hscrc will direct that Crp entity to pay the incentive payment. Again, one lump sum payment to the EQIP entity, and it's typically paid out towards the end of the following year. I hope that all made sense. I'll pause. This might help a little bit. Well, a little bit of a example calculation to help digest this. And let's say, for example, an EQIP entity is participating in 2 episodes, and their baseline costs are $15,000 and $10,000 respectively. Again, for the purpose of this example, we're keeping it clean and not including inflation. So that leaves their target price also at $15,000 and $10,000. So moving down, we see that the volume during the performance year is multiplied by the cost of performance year, and it produces an aggregate performance year price or cost per episode. And now we can compare that aggregate cost back to the target price to determine if savings were achieved. In both of these examples, savings were achieved, and they also met that 3% threshold. And now we then apply that in line H, the tiered savings is applied to that. So you can see where the split is. In this case, I believe we used an 80% split. And that's where we get the final incentive payment. So again, for this example, $34,000 of incentive payment. Because it is hypothetical, there would additionally be a quality adjustment that would be added onto that, and that final check to ensure that it's below the 25% cap. But essentially, that is the flow of how the incentive payment is calculated based off of their performance during the year. Okay, so as in the very beginning of this episode, we mentioned that obviously EQIP is upside risk only, but we do have a DISC savings accountability incorporated into this. And really what this means that if a EQIP entity creates DISC savings in any performance year, they'll be required to offset those savings in the next performance year in order to be eligible to receive incentive payments. If an EQIP entity falls into the lower 2 terciles, so below that 66th percentile, and have 2 consecutive years of DISC savings, they will be removed from the program. And really the logic here is that since it's upside only, and currently we are offering that AAPM status, we want to ensure that providers who participate are participating not only for those opportunities, but also working out to actually drive that cost down and improve quality. The reason why we exclude those participants that are in the top tercile is because, as we mentioned, again, they already are considered very efficient, and it might be harder for them to create savings year over year. So let's get into a little bit of that AAPM status and the quality metrics. Excuse me. So as we mentioned a couple of times, EQIP is considered an AAPM model. And what this means is that care partners who participate in the program are eligible to qualify into the quality payment program. And this benefits the participants in a couple different ways. The first is that potential incentive payment. We put 5% here, but we know that there's been some conversation about that number may be changing. Additionally, the QPP status means that there's exclusion from MIPS reporting requirements and payments adjustments associated with that. So just as note, the timeline for that incentive payment, again, we're using this current year as an example, but for those that are participating in this year, they will get that incentive payment in 2024 for those care partners who are participating in the 2022 EQIP year. So for you all, if anyone chooses to participate next year, that incentive payment would not be seen until calendar year 2025. So yeah, that's basically how that model works. And a little bit about quality selection here. So we talked about how there is 5% that's held back from your incentive payment, and you have to earn it back based off of quality. The Hscrc wanted to choose metrics that are Part B claims measurable. We really wanted to reduce that reporting burden for the entities. And we also wanted to try to create something that could be somewhat applicable across all different specialties, so that there isn't this weird methodology if you're joining as a multi-specialty entity. We wanted it to align with MIPS measures as well. So you can see here the 3 measures that were selected. And this is for performance year 1, that this could potentially change. This is what's going to be used for performance year 2, but we could see this evolving year over year. The 3 that are selected are advanced care planning, documentation of current medication, and preventative care screening around BMI. And again, as mentioned, these are the measures across any episodes that an entity is choosing to participate in. So we'd like to highlight that for each episode that is triggered, these quality measures are assessed by determining if this is performed by any physician in the year prior to the end of the episode. So I'll use that cataract surgery as an example. You have that surgery, we follow it for 14 days. That 14th day, we look back a year, and if any physician, that could be that surgeon that's doing the surgery, or could be a primary care physician that is helping following that patient. It could be anyone. If any physician has submitted these claims over the past year, that beneficiary will have been considered meeting those 3 quality goals that are set. So the note here is that these are measured also off of Part B claims. So there are some claims that we know are not billable, therefore tracking CPTs are also used for each of these claim measures. That's a little bit up to your all's sort of coding department, and we can help with that as if we can. So any questions about quality before I move on, because I'm done this section? Okay, so a little bit about timeline and next steps. So Crisp has developed a sort of one-stop shop for the EQIP entities. And this is what's called the EQIP Entity Portal, or EAP. And that is a single login that a entity uses to determine which NPIs are electing to be in that EQIP entity. It is also where we record and share CMS vetting results, as well as where contracting support, and ultimately where performance data and analytics will be viewed in that. So one of the things, again, if you are saying, yes, this is something I want to participate in, one of the things that can be done prior to the enrollment period is to work with Chris to ensure that there is login and the necessary paperwork set up for a care provider to actually go into the system and do that. Just as a note, only one lead care partner, as we're calling it, needs to have access and go in and enroll your entity. Also, we talked about that administrative role. If a lead care partner decides to delegate their practice manager, like I said, anyone who may have more of an administrative function, they can actually go in and do those enrollment tasks, as well as look at the data and perhaps assist with some analytics. But again, that's that one portal where everything will be selected from who you are joining the EQIP entity with, what episodes you're doing, what interventions you're selecting, and again, any analytics that will become available is all in that one portal. So a little bit about timeline. Annually, the enrollment period is a little bit short. It runs from July to September, the year prior to the performance year. Unfortunately, because we do have to go through the CMS vetting process, that September is, it is a little bit of a compressed enrollment period in order to ensure that we can get that finalized before the start of the following year. So after September ends, I'm going to go through here. After the end of September, we work very closely with the care partners that have decided to participate, and we go through the care partner arrangement process. We finalize CMS vetting status. If there is any participation that needs to be changed based off of eligibility, we finalize all that. And again, Chris helps with supporting that administratively, and we also use the portal very heavily to assist in both the communication and making any changes. And finally, that all leads to a January 1st start. And what we can do now is really these conversations. So you can see Chris is working very closely with different specialties, and Hscrc is working very closely with different specialties to determine what the interest is in these different episodes that are available. And if you chose to go down the route of creating your own ones, working through that process for performance year 3 and beyond. Finally, if there is interest and you want us to meet with a smaller group of physicians or a practice administrator, whoever that may be, we're happy to walk through opportunities specific to a group of providers, discuss more in detail about a specific episode. We do have a monthly subgroup which MedChi hosts, and we recommend, anyone, it's open to anyone to attend. Also, Jean records every meeting, and it's available to view on their website. And finally, really, any questions that you want, we direct people to this equip@cristhealth.org. We will work with our policy colleagues if it's a policy related question, but we're happy to work with anyone. And finally, there is a website on the Hscrc that has the policy outlined for year 1. You can also see a reference to what's called the EQIP playbook. And this is that list of crazy codes. It has a ton in there for year 1. But again, we can share something similar if there is interest in a specific procedure that we just talked about. And finally, just as we mentioned, July 9th is actually the start of enrollment. So that's an important date. And September 1st is the finalized of that. So we really need people to use that short time frame to go into the system and say if they'd like to participate. Again, that's not finalized until January 1st, but if there is any interest in participating, we have to send that list of potential NPI numbers to CMS for vetting. And then we hope people choose and elect to participate and begin in performance year 3 on January of 2023. I think that's all the slides that I have. So we're open to any questions that we can.
I just think back on that, we should add that if you do kind of express the interest in July, and then once you get more information as you get closer to the fall, there is an opportunity to not move forward. And I think that's important for folks to understand. You really want to look at the opportunity in July and see if it makes sense for you. And I would also say that if you go on the MedChi website, we do have, as Jessica noted, all the EQIP subgroup meetings are videoed and put up there. So you can go and watch and see more details on this if you want to learn more. There's hours and hours of videos of our meetings as we've developed and worked on this over the last couple years.
This was really helpful. I came into the meeting concerned and skeptical about, the black box and not knowing, what you'd be measured on. But the lack of downside risk and the fact that you're going to see your results before you have to actually, without being at risk, is really, makes it doable, I think, for people. But it would be nice if we could get more information on what's in those Prometheus groupers at the time of signing up. And we're not going to get that from Prometheus. Can we get that from Care First? I mean, what's the balance between?
We can send you the codes that includes the trigger codes and all the relevant conditions, et cetera.
Okay, that'd help.
And we can send that to everybody who signed up, right, Will, for the webinar?
Yeah. We'll send it. So honestly, we would send it to everybody, but they're a little
proprietary.
Let's why don't we do this? Maybe we'll send them to you, Dr. Glasser, and then any other eye physician who wants to see them, if they're interested in making a determination, they can reach out to myself or Will or Jessica, and we'll get them to them.
Okay.
I would also, again, just reiterate the offer. If you have something, I know you've done work with the national and this issue and in this space. So if you do have ideas on a longer term, bigger project for we're happy to have those discussions and do that work. Just take into consideration that, you know, MedChi is kind of a volunteer in all this. CRSP, who Jessica works for, has a very limited budget, and Will is one person who does lots of things at the Hscrc. So there really are bandwidth issues. But I do think, you know, you guys helping us could be really valuable in developing something new and exciting in the future.
Yeah, well, I think we know where the potholes are. CMS is pushing, you know, for intravitreal injection because it's billions in medication a year. They're interested in glaucoma. You know, we saw that in their RFI. So we know it's coming. We just want to make sure that it doesn't leave physicians disadvantaged because of inability to control things like drug costs. So, you know, very encouraging that drug costs aren't included. They need to be included, but they need to be included in a way that actually empowers the physician to actually have control. So, Gene, I think you and I are on the same wavelength on that.
Yeah, I you know, personally agree with you. I have a couple of scars from having been, I used to work at CMMI, did some work with the OCM model where like the cancer drugs change by DNA type. And if you try to do that in an episode, it's Pandora's box. Yeah.
Well, one day I'm going to figure out how we can do drugs. I think the key is you do drugs with no downside risk, and maybe you start with primary care, where you might have a little more control. But we can figure that out. I think that's a bigger problem, but it's an important one. But in the short run, I think what we've really done, and I got to say that the Hscrc has done a good job listening to physicians and creating the program with physician input. And you can tell by what we're ending up with. And you can also tell by the fact that I think we had close to 1,500 physicians sign up for EQIP for year one, which is not an insignificant number considering that we only had the 4 or 5 specialties that were eligible given the codes we did in year one. So,
that's impressive. I mean, it's been very hard to start an APM, especially for specialists. The system was not designed with specialists in mind. So kudos.
And Dr. Jensen, you get points for hanging on the whole time. Did you have any questions or anything, or maybe not? Okay, I just didn't want to let him out. Ginger, anything else, Dr. Glasser? Some of the others I think dropped off given the length of the meeting, but I think we're in good shape, and we'll share the recording with everybody else.
Yeah, they're the ones that dropped off messaged me and are interested to see the rest of the recording. So it's good stuff.
And we'll share it widely, the recording, so we get it out to the Eye Society. But again, absolutely, if anyone has additional questions, just reach out to MedChi or CRSP or Hscrc. We're happy to help. All right.
Super. Thanks again.
Everybody.
You guys.
Thank you.